All right. Hello, health heads. Welcome and thank you for checking in to this dose of the healthcare uprising. I'm your producer, Jeremy Carr, here with your host, Heather Pierce. So, what's on our agenda for today, Heather?
Today, we are having our first ER doctor on the show, which is super exciting, I think, anyway.
Pretty sure first ER doctor, yeah.
Pretty sure.
I don't recall another.
Nope, me neither. Dr. Adrian Coyce. He is originally from Australia, now is in the Portland area, working as an ER doc in a community hospital. He is super focused on evidence-based medicine. So for those of you out there that don't know what that means, that's basically fact.
Science.
We love facts and science in healthcare. And so he has built or is building a pretty good presence online. Social media. He's got a YouTube channel. Really talking about fact-based medicine because there's a lot of influences out there, saying a lot of things that aren't necessarily, what you want to listen to. But anyway, so he's focused on climate change and the impact on healthcare as well. So we're going to get into all the things today.
And a lot of other things, the hot topic things like peptides and
yeah,
like well.
And just what it feels like to show up at an ER. And, he's going to dispel some myths today.
Yeah.
Set us all straight.
The myth-busting episode of the Healthcare Uprising. So without further ado, let's jump into it with ER Doc Adrian Coyce.
Hi, and welcome to the Healthcare Uprising podcast. Today we have with us Dr. Adrian Coyce, who is an ER doc in the Portland, Oregon area, originally from Australia. Welcome to the show, Dr. Coyce.
Thanks so much for having me. It's great to be here.
Yeah, and I would say kind of a fellow podcaster. You've got a YouTube channel, so so we're all like media people. This is great. So we know what we're doing, right?
Apparently, I'm very much in my. So we tell people exactly. I'm in my infancy with it all, so it's a whole new world, and it's always good to be learning a new skill set later in life. You know what I mean?
Yeah, for sure.
Yeah, totally. I taught myself all this.
Yeah, so, exactly.
You're doing the same thing. It's a fun process.
We're all like a bunch of startups.
Totally.
But to inform and educate in healthcare. So with that, I'm going to give you the floor here. Tell us a little bit about yourself, who you are, kind of your background, and then we'll jump right into our conversation today.
Sure. I'll take you back a little bit, but I won't go too far. I remember in high school, I had a period of time there where I had to go to a hospital. A family member was in hospital and was unwell, and I saw one of the doctors there, and I thought to myself, geez, that would be really fun to be a doctor. And anyway, I kind of flagged that with my guidance counselor, and my scores in high school weren't particularly great. And they had thought, well, you're a good athlete, you should probably do something like exercise science. So I went and did that. I ran my own business, and I was training professional athletes, and I loved it. It was really fun. We were able to train some folks that ended up going to a FIFA World Cup, and athletes that competed in the Olympics for swimming. And I had a really fun time with that for 11 or so years. And through that journey, I got to work with some excellent sports doctors and physical therapists and things like that. And they really inspired me to want to expand the scope of my practice. So I ended up going back to medical school in Australia. And I did that, I guess, in my late 20s, which was actually the perfect timing because I was ready to study and ready to learn. And kind of never looked back. Ended up doing some training in Australia, did obstetrics and gynecology over there. Working to basically provide healthcare for women in rural areas, as well as do a bit of general emergency room stuff, clinic stuff. And throughout that whole process, I met my wife, who's American and lives in Portland. So we came this way and ended up doing a residency in emergency medicine, and the rest is history. So yeah, we're just living here in Portland and doing our thing. And I guess I've sort of migrated into this space online because I think that healthcare providers have probably, done not the best job of getting out into these spaces and filling a void with helpful and accurate information. And because of that void, it's been filled by nefarious actors. And I'm just trying to do my little bit so that I don't see people come into my emergency department that are the victims of that misinformation or inaccurate information. Because I just don't want to see people when they're, very unwell, if it can be avoided. So yeah, that's the long story short.
I love it. Well, I like to say here on the Uprising, our goals are to inform, educate, and to create empathy, particularly for people, we don't understand each other. And so, but it's so much about the information, which is Why, when I found you on TikTok, literally, which, but for the record, I was like anti TikTok forever. And then as soon as I got on there, I was like, oh my God, why did I wait so long? I've met so many really cool people like yourself, obviously, and other physicians like you that are trying to put more accurate and the evidence-based information out there to hopefully speak louder than those kind of wellness influencers that some of them are really great, but to your point, there's a lot of information.
And it's pretty loud. It's going to be hard to shut those people down.
Yeah, but I'm
Totally.
I'm
Totally.
excited that you're here, and so we've got you here to talk about the. Obviously, you've got you are an ER doctor or an ED. Sometimes we hear that, but you've got a lot of other very interesting background, and you're from Australia, obviously, and you said that. Um, I want to start off just to get an idea because people talk about this all the time, like healthcare in other countries versus U.S. healthcare system. I mean, I don't even know how many times I use the hashtag US healthcare is broken. It is. I mean,
Yeah.
it is. There's a lot of people trying to fix it, and part of that is education. So, but what is the difference that you see, having worked in two different countries, like right off the bat, whether it's ER or, other parts of the healthcare system?
Yeah, it's an awesome question, and I've probably answered this maybe 1,000 times since I've been here.
Yep.
And it always changes from time to time, and part of that is because the U.S. healthcare system is so complex. I think that so many people don't understand how it works and what the actual problems are with it. But first off, I would say that the medicine, both in Australia and the US, is the same. We like human bodies don't change. The medicines that work in Australia are the same medicines that work in the US.
Mhm.
And we have amazing providers and physicians here in the US, that by and large, they're just trying to do the very best they can, and they truly do care about their patients. I think where the difference, like the elephant in the room, so to speak, is that the US healthcare system is for profit, and
Mhm.
all of the incentive structure around that completely changes. So obviously in Australia, you have a universal healthcare that is single payer, paid for by the government through the government program, which is called Medicare. And as a result, the most of the hospitals that junior doctors train in are publicly funded, so they're employed by the government. So if someone goes to the emergency room, there isn't a copay, there's no bill. If you if you have appendicitis, you get admitted for 2 or 3 days, you don't get a bill at the end of that time. My wife, she is an American, and she got permanent residency, and like literally within hours of getting granted her permanent residency, she got her Medicare card. And
Wow.
a year later, she had our first child, who had shoulder dystocia and was in the NICU for 3 days, and then on the ward for 4 or 5 days. Didn't have to pay for any of it because it was all covered by the public health system. And then we got funneled
Not
over
worrying
to
about the
a
bills, right?
Correct. Yeah, we got funneled over to a community health nurse, and a midwife came out afterwards to see us. And I think when I think of that, how stressful that was for us in general, to then not also have to worry about where we're going to get the money to pay for this, like that, I think allowed us as parents to like really thrive in those first few days.
Hmm.
And then I compare that with the US system, and every single person has a horror story, either that they experience themselves or someone that they know. It could be, hey, my kid went into the NICU, and well, they didn't have a social security number, so we can't pay for their bill or something like that. It's like, but they were just born. Like, what are you
That's
talking about?
crazy.
So
Yeah.
there's all of these stories that happen, and I think that the incentive structure is different in that, if you don't, essentially, if this system is paid for by the single payer for example, in Australia, the government, versus, it's going to be your private insurance company or Medicaid or Medicare, where's that money coming from? The way that people interact with that system is different. And then because you have the differences in the systems, you have the way that the patients themselves interact with that system is different. So
Hmm.
the way that I describe it is the tolerance for risk is very low in the US, both from patients and from physicians.
Right.
So physicians, they're worried about getting sued because patients are coming, they're paying good money to get the answers to, why they're having the symptoms that they're having. So they want the answers. And therefore, the physicians are, and I feel the pressure sometimes to like do more, do more. We can't find out, we don't find it on the blood test. There's nothing showing up. There's nothing on the urine. Let's do the CT scan. We don't find it on the CT scan. Well, what are we going to do next? Let's do an MRI. And it's like, hold on, do we actually need to do any of that stuff? But the patients are worried about what's going on, and they know that they're going to get a bill from that visit. So they want to get the answer right then and there and get the solution to it, as opposed to leave the hospital, and see how you go, and then come back if you have recurrent symptoms. And so I think that willingness to accept some degree of risk is a lot lower. Whereas when I work in emergency departments in Australia, which I've done, sometime in the last couple of years since I've been working in the emergency room here in the US, sometimes I'll do those situations. I'll be in that situation where I'll get some labs. I'll see a patient and have a pretty non-concerning exam, and I'll say, hey, listen, you're actually looking okay. We gave you some medicine. You're feeling a little better. We could do a CT scan, but there's nothing about the objective data that I have so far that makes me think that you're going to have something bad going on inside your belly that needs admission, needs antibiotics, needs a surgeon. Therefore, I think it's okay for you to go home. And if things get worse, you can just come back and see us again, or you can see your primary doctor. And by and large, patients are totally willing to accept that and accept that risk. Which is, it's a much better relationship to have between the physician and the patient, for sure, because you're essentially giving them choice, and you're not exposing them to, additional testing and sort of continuing to embed them within that system. And obviously, it's less expensive because you're using less resources, right?
Right. And cost is always top of mind, right? I mean, how many times
Totally.
do you encounter patients that are like, how much is this going to cost me? Or I don't want to do that test because it's going to cost me too much money, or things like that, to like,
Definitely.
right? Like to
Definitely.
refuse care for that reason.
Definitely. And exactly. And that's the flip side to that whole piece as well, is that patients oftentimes, I almost never get a patient in Australia who refuses a test because they're worried about cost. Most of the time it's because, hey, I want to go and play golf, so can I just leave now? I don't want to get that done. But oftentimes I'll have patients who, an example, I had a young guy who had been out mountain biking and he fell off his bike. He landed on his leg. He had a big hematoma in his leg, in the thighs, and which was bleeding. So we did an angiogram. So we got on the CT and we saw that he had a bleeding, blood vessel into the muscle in his leg. He was going to be fine, and didn't need surgery. But like the advice was, hey, your hemoglobin has dropped a couple of points. We should keep you in hospital overnight and make sure that we retest it in the morning, and make sure that we've got your leg up, we've got it padded. If you need pain, we can give you pain medicines, and we need to check that hemoglobin tomorrow to make sure that's not continuing to drop. And the fellow was worried about the cost of that admission, so decided to want to go home against medical advice.
I'll risk it, right? I'll take
totally.
my chances.
Yeah,
totally.
Yep.
And that, I think, then those are the situations where patients can get into real trouble, and they can get obviously go home and be very sick. Or even they don't come in. They have the exact same concern. They're worried about the cost. I've got feel a little bit short of breath, or maybe I've got a little bit of chest pain. I won't go in. And then all of a sudden, 3 days later, they come in because, oh yeah, this is really chest pain. And then all of a sudden it's like, well, you've been having a heart attack for the last 2 or 3 days, So,
oh my gosh, can you imagine? That's insane. Like,
just walk it off. I'm fine.
As you're talking, I was thinking about my husband, actually. So he fell off a roof August 28th of last year, 12 feet onto concrete, broke his fall with his left leg. He's a painting contractor. We've done a few episodes about this. And not even going to lie, I called his business partner as I was driving like a madwoman down to the house where this had happened. And I'm like, do not call ambulance. I was like, I can't afford it. I go, that's going to cost me 10 grand. I'm like, my husband's got to suck it up. And I drove him 20 minutes, and then his leg was just from the knee down. It was battered. I wonder, looking back, had we called the ambulance and not had to worry about that cost, would they have gotten him into a much more stable position earlier and minimized the damage? which has now extended his recovery time, the number of surgeries, all of the things. Like that one decision, like maybe, probably,
Maybe,
you
yeah.
know,
I mean, if
who
you
knows?
just think about the simple mechanics of someone who drives in and goes through the triage booth, there oftentimes if there's no room, you have to sit in the waiting room,
Yeah,
whereas if you come in the ambulance and you're clearly a traumatic injury,
right.
we make room for you in the resuscitation bay, so
Yeah,
who knows, maybe
yeah. You
it's
never
a 20
know.
minute delay, maybe it's an hour delay, who knows, it's but either way, like ultimately, the goal should be, well, what is the best for this person? And if the
Hmm.
best is for someone who's fallen 12 feet off a roof and shattered their leg, the best thing is to get an ambulance and go to a trauma center to be
100%.
evaluated immediately in a trauma center. That's what we should be striving for. And we
Yeah.
shouldn't be setting up barriers for people like worrying about cost so that, that will alter that ideal situation. So
Right.
And it's so common that everyone hears you tell that story and they're like, oh yeah, that's what I would have done.
exactly. Yeah,
Like it's not
exactly.
even like it's not a controversial decision in this country to not call the ambulance
It's,
because it's a minimum 10 grand.
oh, yeah.
Yeah.
Like I saw the
And
price
in
tag
his
on.
case, they were probably going to, have to do some work on him in the meantime. That's going to just keeps costing more and more and more. Like it's amazing how fast the cost goes up on things like that.
Yeah. Yeah. I hated that I had to make that decision. This is a really great segue into like the next thing I want to touch on too. So you were working in an emergency room, um, and I'm also too, as I'm talking about this, because I bring this show up at like every episode because I love the show The Pit.
Okay.
um, all the people that are in like the worst moments of their entire lives, like that's what you're engaging with. And of course, in the pit, because it's like a whole day, like each episode is like 15 hours, it's like every possible worst thing. And I'm like, wait, the ER can't be that bad and that extreme ever, can it? I don't know, maybe it can, but anyway, there's like a lot of crazy stuff that happens. What is one of maybe the biggest misconceptions that patients have when they're coming into the ER room? Because you hear people, or the ER department, always like, I don't know. You hear people complain more. You
Sure.
know, it's like the people that leave the bad reviews on Yelp, right? Like they're pissed off about everything.
Yeah.
So the reviews are always going to be bad.
Yeah.
Um, what do you encounter? Like, what do you see most of the time or hear?
Yeah, totally. I mean, well, just to validate your point, shows like The Pit, I think that they to make people interested in the show, you've got to make sure that you get as many bad cases together in one hit as
Hmm.
possible. And I must say that you have shifts from time to time that fit that profile for sure, where it seems
Okay.
like every patient you get on that day is really sick and you have to do lots of different things. Other
Yeah.
times it's not, and it's fairly bread and butter
Okay.
stuff. Um, I think that there's probably, in terms of misconceptions that people have, there's probably two sides of the equation there. You have the physician provider side, and then you have the patient side. And this is where I kind of confess a few things about myself and fellow emergency physicians, is that we are trained to deal with emergencies, and the reality is not everything that comes into the emergency department is an emergency. You know,
Hmm.
gallbladders, traumas, head bleeds, heart attacks, strokes, those sorts of things. Like those are the things that we get trained for. The reality is, and this goes back to our previous point about healthcare differences, is that people don't have access, either access or cannot afford to have a primary physician. So
Hmm.
this emergency department is the safety net for healthcare of our citizens, and folks that live in this country, and we end up seeing a lot of patients for their primary care needs. And I think that one of the misconceptions that the physicians have is that, like, that's not what the emergency department is about. Well, newsflash, it is. That's what we have to deal with. So we have to like strive to be better in the work that we do, and we have to be able to meet people where they are and be compassionate to them. There's, my visit with someone who is there because they, like, they don't have access to their primary doctor anymore and they need a refill on their medications. Like, it doesn't help me, it doesn't help them to get upset with them for coming and using the emergency department in that way when it's clearly not an emergency. But my job is to, like, step up and help them in that moment. So I think that's the first thing. From the patient's side, they almost never get to see what's going on behind the scenes. Um, you see even on like places like social media, all the different platforms, you have people that, will get photos from their videos from their beds of, doctors and nurses like goofing off and chatting away in the fishbowl, we call it, and saying, "What's going on back here? I've been waiting for 2 or 3 hours. Like, no wonder they're taking forever. They're doing all this stuff." Or like patients will say, "Hey, I saw my doctor once and I haven't seen them again. Like, what's happening? I haven't been doing anything." And I mean, the reality is that when I'm on shift, I might have 7 or 8 patients that are active at one moment in time.
Mhm.
And like my standard workflow is that I sit down, and every time I sit down at my desk, I run my list. So I go through each patient and I look, when are the new labs trickling in? When are the new imaging findings trickling in? I'm looking at their previous chart history. I'm going back, looking through clinic notes, seeing what was done recently, what was done previously, what medications have changed. So patients don't see any of that stuff. They only see you for that couple of minutes often, where you're having a conversation with them about what's going on. But the reality is there's a factor, an X factor, significantly higher amount of time that you're spending actually looking through their information, that they don't get to see behind the scenes. So I can understand the frustration in that. The other thing about emergency medicine is that people will come in and they'll be sitting in the waiting room, and they'll see people who come in after them, sometimes 1 or 2 hours after them, and they just get whisked straight back to the department. And the reality is that they have a more immediate life threat than the person that's sitting in the waiting room, and that can build a lot of frustration.
Mm.
And then that part of that as well is some of the structural issues that we have. We don't have enough space. I think that a lot of departments and hospital systems have underfunded space for patients.
Mhm.
So, the place that I work at is a 16-bed emergency room. We're often, overflowing into hallways. We're overflowing into another sort of 4-bed space where we can see more patients. We've converted one room into a double space so that we can quickly cycle through patients. So, it's happening with departments all over the world, in fact, where, we're just trying to like see more and more patients in a more timely fashion. And the reality is sometimes we're just doing the very best we can, even though it's probably not ideal, because we'd like to be able to see people a lot quicker and not have them have these long wait times. But the reality is that's the best that we can do with the resources that we have at that moment. So.
Yeah. Are you operating in a pretty urban area?
Yeah, so I did my training at one of the big teaching hospitals, which was the Level 1 Trauma Center. And
Okay.
then now I work in a community emergency department. But it's kind of like outer urban area. So it's the suburbs, but we have like farming area right near. We have a number of like
Okay.
warehouses, like Intel and Amazon are right there. So, we
Mm.
get like very standard like suburban problems,
Okay.
as well as like a little bit of inner city issues with drug use and things of that nature. And then we get farm injuries. We get the pressures that are on warehouse workers,
Mhm.
working all at all times of night coming in as well. So. Yeah, we get a very big, and we get lots of pediatric patients. So we have a very big mix of folks.
Okay. Okay. Cool. You're gonna ask.
I was just wondering on the crowdedness of the emergency departments around the world. Is it really just a lack of facilities, or is it a lack of staffing, or is it maybe just an overuse of it because people don't understand what emergency rooms are for, and so many people don't have insurance and things like that? Or is it just kind of a chaos thing that you can't really put
I,
that kind
I'm
of
going to give you
description
the I'm going to give you the most dissatisfying answer, and it's all of the above. Uh, and so think about it this way. COVID was a massive issue. We lost a lot of staff because of that. A lot of folks that maybe were going to retire in 5 or 6 years, they brought that forward. They got overworked. They saw tons of trauma. They have lots of trauma that they're dealing with and emotional distress from that. So they left the field. So we're chronically understaffed. I read some statistic by 2030, the US is short something like, I don't know, it was something like 200,000 or 400,000 nurses short,
Ooh.
across the country. And I think that by the same time, we're like 80,000 physicians short as well. So like staffing shortages is one thing. Two, investment in infrastructure is another thing. Like is we should be building emergency departments now for the emergency department we need in 5 years' time. And
Right.
the reality is that just isn't happening. It's like we built it once and we're going to wait until like we're literally bursting at the seams, and then we'll start a funding round. And then 10 years later, maybe we'll build the emergency department we needed 5 years ago. So the infrastructure is another thing. Another thing that's a big problem is that we actually, and this is happening in Australia as well, is that the reimbursement rates for primary care is going down. So you're actually seeing a shift of people moving away from going into primary care. And that's happening a lot in the US, partly because the reimbursement rates for primary care,
Oh yeah.
preventive care is not very good. So people don't have a primary care provider. Where do they come? They come to the
Right.
emergency department. So
Or you
so I
have to
think
wait, right? Like 6 months
totally,
to go see somebody. That happened to
totally,
me. And I'm just like, well, what do I do in the meantime? Yeah.
totally.
Crazy.
So
Yeah.
so it is a little bit of all of the above. And I try to, like, to your point of one of the goals of the show is like meet everyone where they are with empathy and compassion. And
Hmm.
people are just, honestly, the vast majority of people are just trying to do their best. And we just have to meet them where they are. And my job on that day is to help them through whatever they're going through. So and I can't speak for everyone, obviously, but I really do believe that the vast majority of people that are in healthcare, they have the exact same mentality. That's why they go into it. No one works crazy hours until they're in their mid to late 40s, getting paid nothing, and to do this career if they're not interested in helping people. You know what I mean?
Oh,
Oh
gosh.
yeah, totally.
I've worked in healthcare since 2002. Now, albeit I've been on the corporate side, right? Even on the payer side. And now having been in like the startup space for a while, and Jeremy, you've probably heard me say this. People who work in healthcare, whether you're on the front lines as a clinician or you're in, even like me, kind of in the administrative part, um, it's people who really like I want to help people. Like I don't care about selling Pepsi, right? Like or toilet paper. Like cool, everybody drinks soda and wipes their butt, right? Like
Yeah,
but healthcare, I know for the companies that I'm choosing to work for, right? I know that the at the end of the day, their goal is to help patients, right? Which is also me, right? That's all of us. And I'm invested into that. Personally. Like I couldn't see myself in another industry because I know that my work is somehow or another, this like kind of trickle down effect is that my work is hopefully going to change somebody's life, right? Or improve their health. So people that are in the healthcare industry are the best people, no matter where you are. That's what I like to say.
Yeah, I always say that all nurses are superheroes.
Yeah,
totally.
they are. We actually had, I was thinking when you were talking about the nurses shortage, doctor shortage, I have like all these things going through my head, like Nurse Meg who came on. She did a show with us. And we also know that some of the issues around like at least nursing shortages is also a decision often from the actual like hospital administration, right? Like doing more with less. And
Yeah,
yeah, and sometimes that's actually people, which truthfully, I know that just from working on the corporate side. It's the same thing. I think that's just everywhere, right? Like everyone's just
totally.
trying to cut back. I don't think it's specifically to one, even one industry or one specific role, but
No,
we pay the price for it, right? And
totally,
particularly at the in the ER. So,
totally. Yeah,
yeah.
absolutely.
But I want to talk a little bit too. You've got a bit of a presence on YouTube. What is it? Overheard in the ER, right? Did I get
Yeah,
that right?
overheard in the
Overheard in the
emergency room.
emergency room.
Yeah.
And how I found you on TikTok. And one of the things that you're doing really well is spreading truth. And kind of, fighting the misinformation out there on social media, which I think probably lands a lot of people in the ER in your care. Um, so,
Eating those Tide Pods and stuff. Oh no, that was TikTok, wasn't it?
oh my gosh. Yeah. I mean, just like the different things that are out there that people are selling, pushing, talking about, building these presence online about, I don't know, supplements and all this stuff and
Looks maxing.
looks maxing. What
Oh,
can you,
It's the most aggravating trend ever.
right? How do you
Horrible.
deal with that? Like, I imagine you probably encounter that a lot. And then, and again, like your platform is about spreading truth and fact through evidence-based medicine, which I love. But you're fighting the good fight.
Yeah, so I guess my interest in this is I'm involved in a misinformation committee through the Society of Academic Emergency Medicine, and we're looking at
Oh.
what we're trying to basically create some consensus guidelines around
Mhm.
how what's the role of emergency medicine physicians in battling misinformation, particularly with regard to public health. And I think the reason why I started that podcast, Overheard in the Emergency Room, is that the vast majority of people who come into the emergency department are people who are not currently following the recommendations that have been known to be true about what makes you healthy and live a long life for decades. So like I call them the five pillars, the five tier one habits that are most important. So making sure you're eating a diet that's rich in plants, making sure that you're exercising regularly, doing some sort of physical activity every day, 30 to 60 minutes, doing some weightlifting or some sort of resistance training if you can, sleeping well, which is a whole massive topic to go into. That's at least 7 or 8 podcasts by themselves. Making
Probably.
sure that you're doing some sort of like relaxation meditation practices and having a primary physician. Like if those 5 things were in place for everyone, and we've got so much robust data to support those things, like we would be in such a better state when it comes to chronic health and honestly people's happiness and their ability to age well. And part of the reason why I wanted to do that is that you have, because physicians are not typically on these platforms, like, and the people who have the knowledge and are willing to talk about, really what is boring guidelines and boring evidence and
Mhm.
making it palatable for everyday folks. Um, because of that, you have these charismatic people who basically build platforms for themselves and say, I've got the protocol. And a lot of it is BS, it's not real. So, and it's sort of taking some sort of idea that's on the fringe and there's maybe a kernel of truth to it and really amplifying that. And it makes people think that that's exactly what I have to do. I will go to my gym or just see people in my neighborhood, and you'll see some like prominent podcaster do something about how wearing weighted vests is the best way to improve your cardiorespiratory health and improve your VO2 max. And literally within a week, everyone that's doing a walk is with their dog 1 week was not wearing a weighted vest and is now wearing
The
a weighted
weighted
vest.
I've
vest
been seeing
trend.
so many joggers with weighted vests in Flagstaff
It
lately.
is
It's
it is
crazy.
all over my
It's like
feed.
they're all wearing weighted vests.
It's like a midlife woman trend right now too. So I'm just like, oh my God, am I supposed to be wearing a weighted vest?
Totally. And then here it is, right? Is that everyone feels the pressure to do that, because they see that, oh my gosh, it's everyone looks to be doing this. That's something I need to be doing. And like the whole point of that particular podcast is to like take a step back and go, okay, what's the guiding principle here? Um, and I don't want people to like be going out and spending all their money on these gadgets, like for them to go out and do like a half-hour, 60-minute walk with a friend, with a family member, with their dog, get out of breath, get their heart rate up into the correct zone. That's what you need to do. And you just need to do that regularly. And that's the bottom line. And my hope would be that if folks were able to listen to the information that I have and then put that into practice on a daily basis, then they're either going to delay their presentation to me or avoid it altogether. And then when we're in the emergency department, I don't have time to tell them all of this stuff because
Yeah.
we've got so much time pressure. And maybe that's their only interaction with the healthcare system for 3 or 4 years, in their early 40s or in their 50s. And I want them to take some kernel away from that, but it's very hard. So hopefully this is some information that they can like lean on to be able to, change some habits that they have about their life and live a happier and healthier life that's long.
Yeah.
So that's probably the biggest thing, right? The other thing is the smaller things that I'm seeing regularly with like true like misinformation. Like for example, I had a young man the other day who had injected himself with one of these peptides, and he came in
Yeah.
with an allergic reaction, and it was horrible. The guy had hives all over his body. Fortunately, it wasn't anaphylaxis, but that's what he was worried about, right? and ended up like giving us some antihistamines, and because he had this like very widespread rash for a number of days, we gave him steroid as well, and he seemed to feel a lot better and went home. But this is just an example of one of those like trends that is not benign. Like honestly, wearing a weighted vest, you can get them on some online store for $25. That's not going to
Yeah.
cause you that
Maybe
much
you
harm.
waste your money, but that's about it.
Totally, totally. Whereas a peptide, you're injecting something that has no data behind it to into your body. You have no idea if it's safe. You have no idea if it's effective for what the indication was that you're injecting it into your body in the first place. And I think what's important is there's so many people out there online in this space that are talking about how to spot that. And I think that there's a couple of really helpful tools that you can use that I think people would benefit a lot from, which we call pre-bunking. So like making sure that like cherry picking is one. So if you know about what cherry picking is it's the type of person that's going to pick out one article and like rely heavily on that article as the evidence for the recommendation they're giving. And when you know about what cherry picking looks like, you listen to what they've got to say, and then oftentimes they'll flash up the study on their screen, so you can just go and search that, and like all of a sudden it's a study on mice, or it's a study on what happens in a petri dish to different muscle cells or something like that. That's evidence. That's cool to understand. But if you're going to make a decision to take that pharmaceutical product and put it into your body based on that, that is totally wild. And then at the same time, the people that are selling that and using that as a justification, they'll look at something like, for example, the mRNA COVID vaccines and go, there's no evidence to support that they are safe and effective. So we're not going to put that rubbish into my body. Whereas they've had stage 1, 2, 3, and now in stage 4 trials, basically with ongoing maintenance involving 40,000 people and animal studies before that, to determine that those pharmaceuticals are safe and effective. So I think it's important that people understand what they should be looking for when they are consuming this sort of content online. People are not able to do the research themselves.
No,
I rely on no, no, I rely on specialists all the time.
sure.
I'm not a neurologist, so I want to hear what the neurologist has got to say about how you deal with stroke. I want to hear what the cardiologists have got to say about dealing with heart attacks. And then what's the standard of evidence that they use to like make the recommendations that they're making.
I am glad to hear that an actual like misinformation committee, or is that what you
It's a consensus committee, so
can?
yeah. So it's basically we're trying to we've recognized that that misinformation is a big problem.
Yeah.
In fact, I think the UN recognized that misinformation is the third biggest threat to humanity.
Okay.
In a
And
recent
that's not
article.
just an American problem. That is a
Nope.
global issue.
Global issue.
Yeah.
Yeah, climate
The
change
biggest
was
threat to
number one.
humanity is humanity.
Yeah.
Oh, going deep there, Jeremy.
Just saying.
The philosopher speaks. I'm really glad to know that actually exists. And by the way,
Yeah.
like totally having, because I'm always having my marketing hat on. I come up with taglines and campaigns all the time. I did yesterday when we recorded. It's make evidence-based medicine great again.
Totally.
Yeah,
I
right.
love it. I love it.
Mega.
Mega.
You can steal that too. I'm giving all my good stuff away lately. I'm like, steal it, use it. It's a good one. I'll just be
Sounds
proud
good.
when I see it in use. But I
Sounds
mean,
good.
that's kind of the goal, right?
It's a huge uphill battle because the misinformation is, I mean, that some of those people are literally getting paid to specifically put out that misinformation.
Yeah.
It's how they're making their living, and they know they're doing it, but they're getting the money, so they just do it.
What's the craziest thing that you've seen come into the ER, like around that stuff, right? Like this kind of like, oh, I've been, I don't know, injecting myself with whatever, and now I have jaundice or something like that.
Yeah, yeah. I mean, I don't. I wouldn't say that I've seen a lot of like very, very crazy things from that,
Okay.
and realistically, the just in terms of sheer volume, those direct victims of misinformation from crazy things like that is actually very low.
Well, that's
Um,
good to hear.
Yeah, but at the same time, I've had people who've come in with a heart attack, and they are fully convinced that having a sky high LDL cholesterol is okay. In fact, is healthy for them.
What?
And that's one of the big problems I see on social media, and it probably is a
They want to think it's good to have that.
yeah. Yeah. So
I'm so
the
confused.
myth, the way that the purveyors of misinformation will present this is that the brain is made up of cholesterol. Therefore, why would you ever
Oh,
want to lower cholesterol?
oh
And it's basically a ruse to push, a high saturated fat diet, or give people permission to eat a high saturated fat diet. And it's a fairly small but very vocal and very noisy and very sticky part of social media. I've had a number of people.
sticky.
Yeah, yeah, exactly. And there's a lot of people that I've seen who've come in and have told me blank to my face that, oh, that's when I've said, hey, I looked at your recent lipid profile and you're here with chest pain. Luckily, you're not having a heart attack today, but you really need to get your cholesterol under control. You've got this like very significant risk factor of something, LDL cholesterol that causes atherosclerosis, and it's sky high, like and you're not on a lipid lowering therapy and the right age group, like you definitely need to talk to your primary doctor about, or even go to preventive cardiologist to try to get that under control. And they'll stare at me blank in the face and say, LDL, like cholesterol is not a problem. Cholesterol is not the cause of cardiovascular disease. Inflammation is. And it's like, oh my God, what are we doing here?
Oh,
So
that's frustrating.
You're telling the doctor what? Oh my God.
I'm sure
yeah,
that
That's the
and
and that's the real problem with misinformation, though, right? Is people end up thinking they really know something,
they're
and it's all
smarter
nonsense.
than you.
And then they talk to someone who actually knows. They go to the person specifically for help, and when they tell them this is wrong, they're like, "Oh no, it's not wrong. I
Yeah,
totally know that's right because the internet told me."
right.
Like,
yeah.
why go to the doctor? Why do they even go to the doctor
It's
then?
like I don't tell an electrician how to do their job, right?
Yeah, like it's
Unless you want to get electrocuted or burn your house down, by all means.
right. Like you don't go to the contractor and say, how do you build this house?" And they show you, and then you go, "Oh, that's not how you do it. I'm going to do it this way."
Actually, some homeowners
Like,
do that.
Yeah,
and how does the
yeah,
house come out?
Well,
yeah.
That's
A
because
lot of
crazy.
not great,
it
and it
is.
pisses
It
all
is
the
very crazy.
contractors
It's really the mind-blowing part of the whole, and it's not just medicine, it's everything now.
Oh, right.
It's like any field you want to talk about, there's going to be some kind of misinformation like that
Yeah.
where people are purposefully misleading.
It's almost too much information is out there now, right? That's like made people dangerous with
Yeah,
their, I don't know, confidence, I guess, or more. It's not really confidence. They just think they know
yeah.
things.
Yeah.
All you
Well, it's
need,
telling them
all
what
you
they
need
want
is
to
FOMO.
hear. They
Yeah,
want to think it's okay to eat Twinkies all day, so they find the person
exactly.
online who says, "Oh no, Twinkies are really good for you," and they're like, "I'm just going to believe this person."
Yeah.
That's
Well, you
really how it works, though,
absolutely
right?
you absolutely hit the nail on the head. Confirmation bias is like
Confirmation
humans are
It
uniquely
is.
susceptible for confirmation bias. I like this about my life. I like that I can eat this steak every day. I like that I can like sit on my couch and not, exercise every day. So when they come across someone that tells them that that's okay, I trust that person empirically. So
Yeah.
Yeah.
like that's definitely a massive factor. So, and you know
Yeah.
what? We need more research on how to deal with it.
Yeah.
And it's a priority that has not been put to the
And
front of the pile.
and the real thing is it has such direct effect on physical health, but it's really a mental health. It's a psychological thing that's
Mhm.
leading people to have all these bad physical behaviors, right? So like you almost
Yeah.
need to go to the mental health field to figure out how to fix that, I would think.
Yeah. So many things type. I mean, heck, I was trying to justify that diet I told you about.
Yeah.
I was like, so I can have anything that grows out of the ground or like animals, right? Could not remember the name of this. It's more of like a lifestyle, I guess, type of diet. I did it a couple times. Anyway, I can't think of the name of it, but I was like, potatoes. I can eat potatoes. I was like, and I justified eating potato chips, which I knew were not good for me. But I was like, but it was a potato and therefore it's fine. And in my
Yeah.
head, like I would say this to myself and I would 100% eat potato chips and try to convince myself that it was okay. Meanwhile, I'm like, I know this is so bad for me and probably making my LDL cholesterol go sky high. So, but
Don't
I'm
eat
losing.
Yeah.
processed foods. Don't eat processed foods.
Yeah,
Eat
totally
real whole
guilty.
foods. Eat potatoes, not potato chips. That's actually really where the line's drawn.
I know this. I'm like, I knew it. but I was still like, I can have these potato chips.
Well, there you go. That's the confirmation bias, right?
Totally.
That's the mentality. You just need to something that tells you that it's okay to eat potato chips because you want to eat potato chips.
Right.
Yeah.
Well,
Yeah.
I'm not on that diet anymore, for the record.
Good on
I have kind of a tangent question on all that.
you. Sure.
What do, I don't know if this is too out of left field for you, but what are your thoughts on the GLP-1s? Because I don't really trust those things. I've known a few people now who've gotten on them and they literally just stop eating. Like they'll go
Yeah.
days without
Me?
eating food. I
I'm
wasn't going to
one.
call her out, but she is one of those people.
I admit it. I'm taking one right now.
And these things,
Yeah.
to me, like it feels like they came out of nowhere, and all of a sudden everybody's on them, and it's like, oh, I can just lose 100 pounds by taking this drug and not ever changing my food habits, and or developing different unhealthy food habits.
Yeah.
Isn't
And again,
long term food health? It's like you have to establish a healthy relationship with your food, right? And just stopping eating isn't a healthy thing. So to me, it's like, do you think these things are actually helping, or are they just causing a new set of problems?
overall, I think again, this is a nuanced answer, which is might be a little frustrating. But the bottom line is, I think that history will look back on these class of drugs, and they will be seen as some of the most amazing drugs that were ever developed.
Okay.
Um, but here's the problem, right? Is that you have FDA approved versions of these medications, and then you have compounding pharmacies that are spitting them out like crazy. And if the indication is for a management of obesity and weight loss, that when you look at the guidelines for obesity, it's not just take a GLP-1 and off you go. It's work with a physician as part of a multidisciplinary team. So you have a psychologist, you have a dietitian, you have an exercise scientist, you have a bariatric surgeon, and you have an obesity physician, primary care physician. So you have this team that one, you take the medication to get rid of. There's a fella on social media called Terry Simpson. He calls it his food noise. So one, you actually change the physiology of your body and the way that your brain gut axis is interacting with each other, such that your cravings for food and the way that you interact with this obesogenic environment that we live in, where there's a million calories available for 50 cents on every convenience store, corner. It takes that away using the medication, and it regulates your appetite signaling. And then being a part of a multidisciplinary team, you work with your dietitian, your psychologist to figure out, okay, how am I going to, one, put together a diet that now I'm not going to be eating as many calories? How am I going to make sure that I'm getting the right foods into me so that I get all my micronutrients and get, enough protein to support muscle growth? I'm not going to end up with any deficiencies. And I'm going to build some new habits through exercise so I can do resistance training so I don't lose weight with, my exercise scientist or personal trainer or whatever it is, so that I've got all these new sets of habits while I'm losing weight, to make sure that if ever, I'd want to stop the medication at some point down the track, then I'm like got all these habits that help maintain the weight loss that I've already gained. But this is America, and
Oh, yeah.
we live in a capitalistic society. So like, there's people that have like jumped on this and been like, people want the number to going down, and that's we've got this tool that can make that happen. So I have people who do that, and who have come in and they've had vomiting for weeks, not weeks, they've had vomiting for like 3 or 4 days persistently, haven't been able to keep anything down. And they're in one of these like online GLP-1 dispensing companies, where they start at like 0.25, and then next week you go to, well, 2 weeks later you go to 0.5, then 2 weeks later you go to 0.75, then you go to 1. And it's like, okay, well, what happened from when you were on 0.25 and you went to when you were on 2.25, how much weight did you lose? And like, oh yeah, I was losing weight, I was losing like 5 pounds a week or something like that. It's like, so why'd you go up? I was like, well, they told me to go up. And it's like, it blows my mind, because that is not what the guidelines for obesity care recommend. They recommend that you make an individualized approach to that person, based on what their needs are. Well, this person's already losing weight at 0.25. Why the heck are you changing the dose? So I think that I'd 100% acknowledge that there's problems with the way that these medications have exploded, and I think part of that is because there's some intention from folks that are maybe not providing adequate care for the patients that actually need it. And it's the same thing. The people that who really need it the most are probably not going to get as ready access to it, because the market is like doing its market thing, and it's like putting taking resources away from those folks that really need it in a more
I'm sorry.
comprehensive way.
Yeah.
I'd like to at least call myself out on this, because like going through like perimenopause, menopause, I've been slim my entire life. I've been active. I've never been a person who like overeats, like eats terrible, you know what I mean? But like perimenopause like has been like a whole nother world this last 2 years, where I'm just like, I cannot drop a pound to save my life. Like always, I was a runner for years. I got into spin because I can't run anymore. So I do cycling. And now I'm just like, I actually feel like I'm different, right? Like, so like, I'm like one of those people that like, I am active. I do generally eat pretty well. And so this is actually helping me do something that I have done before, but it's like actually dropping the weight, because I have not been able to drop any weight. And I know that's a midlife thing. So, okay, I might be defending myself here a little bit, but I was like, I need something to like get me off of this space that I literally, all I do, I breathe and I gain weight. Like, I'm like, this has never happened to me in my entire life. And I'm like, this sucks also. And it's not fair.
Yeah, I mean,
But
it's a tool. It's a tool
yeah,
that should be leveraged in a way that
hmm
makes sense. And
I agree.
and as a tool in the hand of a master carpenter is going to end up with a piece of furniture that is very beautiful compared to the
Right.
tool in the hand of someone that doesn't know what they're doing. So
So true, because I have also seen that, right? Like,
I'll make you a chair. Just be wary of sitting in
yeah.
exactly.
it.
But there are people who I've seen not change a single thing, right? And weren't even interested in that even before. And I'm like, well, that's how you got there. Or you have other issues that are causing you to overeat, right? Like that's like a mental health problem. That's a psychological thing, right? That's an addiction problem. So I'm kind of, I think maybe a bit of an anomaly there, where I don't have those issues, and I always have been active, and I actually do like to eat pretty well. So,
It's kind of
but
reminding me of ketamine right now, in
mm,
that it's, if used properly with the proper integrations and everything else,
yeah, that's a good
it
metaphor.
can be like a miracle drug.
Mhm.
But if you misuse it, it can very quickly become destructive.
There you go.
Because, like you're
Yeah,
saying, you got people showing up and puking for days because they're taking too much of the stuff.
Right.
yeah, yeah, and I mean, ketamine's another good example whereby I think that we need better research to get some cohorts together and see what we can do in terms of treating mental health issues, treating chronic pain.
Mhm.
And that obviously takes money, it takes funding, and it takes priority. And oftentimes, like, our institutions like the NIH have been like literally world leaders in terms of funding groundbreaking research to get
Mhm.
trials like this done. um, and as there's been massive cuts to that area
Mhm.
recently, then people are going to take it into their own hands and
Yep.
do those sorts of things. And maybe they just can't. No one can afford to run these trials, privately. So it leaves the door open for people with nefarious intent to come in and just make some money out of things that may not be fully evidence based yet, or we don't know what's the best way to approach
Mhm.
it. So anyway, that's
Yeah, it's like they're selling you something they don't even understand. They just want to sell it to you because they know you want it.
Yeah.
yeah. And this is coming from
Okay.
someone who uses
America.
ketamine every day, and I love it.
Oh
It's
yeah.
one of my favorite drugs to use for people. It's
Yeah.
very it's a very helpful tool in the emergency department. So
Oh, there you go.
My husband talks about his ketamine trip when he got his leg reset
That's one of
twice.
my favorite episodes, man.
He is
Jake
wild.
part 3
He
was
needs therapy.
so good.
I was like,
it's
buddy,
therapy.
you need to do some integration work here.
Therapy.
Like, I'm not even kidding. I actually think he does.
He really probably should, though.
Yeah, I really do. I'm looking at the time, and I know we're running out of time here. I wanted to talk
Wow,
about,
that went fast.
yeah, I know, right? I wanted to get into like some of the work and the interest you have around the effects of climate change on health. But I know we're running out of time. Can you stay on for a few extra minutes? And because I
Yeah, yeah.
really want to touch on that a little bit. All right, cool. Let's do it. Yeah. Share a little bit about that, because I think that's really unique. I haven't met a physician who has that focus, but we all know. climate change is affecting health.
It's
Like, I mean, it
huge.
doesn't matter where you are, what country, what continent you're on. So maybe can you kind of share a little bit about what you're exploring there? And then we can shoot people over to your YouTube page to really kind of dig into some of that with you.
Sure. Yeah. So, I mean, again, I'll go back to the start because the story is always the important part, right? When I first moved to the US, I loved to trail run, and I was running through some trail in Forest Park in Portland here, and it was the days before I had a decent set of headphones, and so I didn't have any in. I was just listening to the trees and the stream and birds and stuff like that, and I was like, my God, what if my boys never get a chance to experience that? So that was kind of like that like aha moment where I said to myself, you know what, I need to learn more about this. And then you start seeing it in the emergency department. You see people like the obvious ones during disaster or extremes. You have your extreme heat, your extreme cold, you have your wildfire events and like high smoke days.
Hmm.
These very obvious things where you get, and then I started looking into the literature on it, and we're looking at sort of like 10 to 20% higher presentation rates on days where you have high particulate matter. And then you have increased mortality on those days, higher cardiac arrest rates on those days. So
We deal
like,
with that a lot here
Yeah.
with the
yeah, totally.
prescribed burns and all this. Yep. Hmm.
Yeah. So it's a meaningful, like 10 to 20%, for example, we see like on a busy day, our small department will see 150 patients. So, it's around 20 or so patients for each physician. So if you get a 10 to 20% increase, you're looking at 2 or 4 extra patients a day. That's a lot. Um, so it's a lot of work basically, for the department, and it's more people that have to go through a bad day. Then we look at the way that we're changing our climate. You have like aeroallergens, for example. They will be present for a longer period of time. So people who have asthma, people who have COPD, they're going to have longer exposure to those pollens for a longer portion of the year. Therefore, there's increased like chances for them to have an exacerbation of their disease. So like I think in emergency room, like we are like the prime place to experience the effects of climate related illness. And I think
It's
the
because
big
it
the big
happens
thing is
urgently, right? Like
totally,
often.
yep,
Yeah.
yep. And then now I'm trying to figure out, well, how do I do this? Like, what's my job? Because I'm not gonna like, I can't treat the climate. I can't give the climate an antibiotic or something like that. But what we can do is we can talk to patients about linking those two together and say, patient who's got COPD, patient who's got asthma, patient who is diabetic and has insulin, like how are you going to store your like drugs that need to be refrigerated on a hot day, or when you lose power because we
Mm.
have a smoke event or a wildfire?
Brownouts, right? When they do like
Exactly.
the,
Yeah.
yeah.
So talking to patients about that in those moments where you actually are seeing them interacting with the healthcare system, I think it's a mandatory part of our job. And that's all,
Hmm.
anyone working in clinics, anyone working in the emergency department, these are important things that we must do. So
I
yeah,
hadn't thought about that. That happened out in Doney Park. So here, similar, kind of tied into this here in Flagstaff, east side of town. It's called Doney Park. They shut the electric off. We had super high winds. We get really high winds here,
It didn't snow this
and
winter.
we barely had any snow again. Okay, climate change is real, and so we're like kindling. We're like ready to spark on fire. They shut the electric grid down on the super high windy day.
They shut it down for Doney Park, Appalachian, or the stuff behind Safeway on Cedar there. That whole neighborhood was black.
It
Like
was a
half the east side was
Well, it's a
black.
pretty big area. And so what happens to people who are running oxygen, right? Like my mom's on oxygen now. Like what if that was us? What if babies that are home from the NICU? What about I don't know, the people that need to keep the refrigerator, like you were saying, what
yeah,
happens to them, right? Like
yeah.
they
Or like the
might show
elderly,
up.
the
Yeah, they might
elderly
show up with you.
person who is like very vulnerable to heat, because as you get older, your
Yeah,
thermoregulatory system, the ability to sweat, it just naturally gets worse. So what if their air
right.
conditioner shuts off for 3 or 4 hours and they've got maybe a
Or
little
you
bit
don't
reduced
have
mobility?
AC.
They don't have AC, and you're exactly, you know.
We don't have AC here.
Flagstaff doesn't have AC because we didn't used to need it because
No.
it never got out of the 80s. It never got even
Yeah.
into the 90s.
Now it's
And
getting
now it's in the
hotter.
90s all summer.
It's
And
staying hotter longer.
my money's on we hit 100 this year. Like we're going to hit 100 in Flagstaff this year,
That's
which it never used to hit 90.
that's a real problem. Like what happens, like my mom's 84. She's on oxygen. She has heart she's in heart failure. Like I don't have AC in my house, right? Like we have window units, but and how unaffordable it is for most people to put AC into their
Correct.
home.
Mhm.
So then
Yeah.
what happens to them?
It's not even really an option for most people.
Yeah,
Yeah.
everything comes back to healthcare. Just everything. Like things you don't even think are connected to healthcare are connected to healthcare.
Mhm.
Yeah. And then so then that's when I talk about, climate change and action on
Mhm.
climate change is everyone's business.
Yeah.
Like even when you're talking with your financial advisor, for example, like are they the type of person that's gonna recommend you invest in companies that are supporting fossil fuels, or are they companies that are
Mhm.
supporting sustainable, climate sustainable, ventures? So
Right.
there's lots of different ways that climate ties into all professions, but specifically within healthcare, I think it's something
Yeah.
that's super important to talk about.
There's malaria and yellow fever in Florida now
What?
because it's warm enough. It's become
Mm.
it warmed up just enough that all these tropical diseases that couldn't live there before are now able to live there. There is malaria and yellow fever in Florida.
Mm.
Never
Yeah,
used to be
and
a thing.
I mean, and Lyme disease is another thing where we have
Yeah.
like developed our urban sprawl and gone into areas
Mhm.
which are now interacting with the ticks, and I think also like things like chikungunya is another mosquito-borne vector. The likelihood that
Mhm.
moves further north. As we get hotter and hotter, like emerging illness diseases is a massive problem.
Wow.
Um, so
Yeah.
yeah, I think everyone has to take a role and has to do something.
Mhm.
And honestly, the biggest levers that you can pull is the way you use your vote. Um, this whole concept of individual responsibility, it's like a drop in the ocean compared to
Yep.
what you can do by, like, making sure that we have good regulation on emissions for
Mhm.
very large companies. And healthcare in the US healthcare sector, if it were a country, it would be in the top 15 global emitters of carbon emissions. Um,
Wow.
so
Wow.
it's massive, 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 and so
I
we're
had no
not we're
idea.
not immune to that. So we have a responsibility, again, an inherent responsibility to make the way that we operate more sustainable. So
Mhm.
less CT scans, less use of single-use equipment, because all of that has an emissions footprint. But when
Mhm.
you're and then, like, thinking of vehicles, like ambulance vehicles, transport vehicles, we're moving patients back and forward. Where are we getting our energy from to power our facilities? Are we like prioritizing using renewable energy to power our hospitals? So it's I don't know. You can't be the part of the system that's responsible for it and not do something about it. You know what I mean?
Yeah.
That's a wild stat that they're like the 15th biggest producer of something that counteracts their own work.
Yeah,
And
That's
hospitals have huge roofs. They could put in plenty of solar panels up there.
hey.
exactly.
Yeah. Holy mackerel. Boy, well, we have covered a lot of ground, and thanks for staying on a little bit longer because I really wanted to talk about that climate change piece. But
Yeah.
before we wrap up with you, and I want to mention too, and we'll put it in the show notes, definitely go follow your YouTube page so you can, if you're interested in the climate change stuff, if you're interested in actually learning about evidence-based
Links are in the
medicine,
show notes.
we'll put it in the show notes. But we're going to continue this conversation, myself and Dr. Coyce here, in another show, little teaser. Um, if you like the show The Pit, you're going to really like what Dr. Coyce and I are going to be doing together um, in a new show that we're going to be launching called Inside the Pit. So, a lot of the conversations that we've been having here today, I think we'll probably get into those a little bit more as we
Launching in
I
like
hope
a
so.
week or two on YouTube
yeah.
I hope so.
and
I think it's
audio
going to be
player.
really fun.
Yeah. Yeah, exactly. So, we've got
And I get to produce a podcast I don't have to host
yeah,
this time.
yeah, exactly. So it'll just be me and you, and we'll get to dive into all of these topics a little bit more deeply, because we're
Get the real scoop on what's going on in the pit.
yeah, straight from the ER doctor's mouth. So
I don't even watch the
Yeah.
pit, and I'm looking forward to that.
yeah,
I
it's
haven't,
gonna be.
admittedly, I haven't watched a single episode yet.
I'm so glad.
Oh,
Was thinking about starting to watch it, and then we met and we chatted about it, and I said, nope, I'm going to hold off and I'm going to wait for this show. So
I am
it's
so
going to
glad
be,
you are.
yeah,
by
it's going to be
by
a
the
lot of
time
fun.
this episode airs, like a month after recording, you guys are going to be expert.
Yeah, we're gonna have this figured out. We're gonna sound great. But thank you so much. I'm great. I can say out loud I'm grateful for TikTok for once, because I found you, and so I'm so happy to have you on today, and kind of what the the world is opening up for us with the new show. So but anyway, thank you
Cool.
for bringing your expertise and your perspective to this platform, for our listeners. I think it's exactly what they need to hear. So.
Sounds good. Thank you so much for having me. I really appreciate it. Yeah, and anyone that wants to follow the work I do, please jump on the socials. It's super helpful, and it'll make me feel better about talking to a camera. Make sometimes feels like you're not talking to anyone.
That's right. And it's Dr. At Dr.
Yeah,
underscore, yep,
yeah,
COIS,
yeah.
overheard in the emergency room. And I think that's all your handles on social too, right?
Correct. Yeah.
Cool. All right.
There you go.
You know where to find him. Awesome.
Awesome.
Thank you so much. This was
Thank you.
fun.
Thanks for joining us on the Healthcare Uprising. Make sure to hit those like and subscribe buttons before you go, and take a moment to think of a friend and hit that share button. You can find us on all the major audio platforms, and we've got video on YouTube if you want to watch us in action.
You can also find us on social media on LinkedIn, TikTok, and Instagram. Just search Healthcare Uprising to find us. And if you're a new company with a cool new product, if you're someone innovating alternative methods for the health and wellness space, or if you have a personal healthcare journey you'd like to share with us here at The Uprising, please email us at healthcareuprising@gmail.com, and we'll get back to you about coming on the show. Well, that's all for this dose of Healthcare Uprising. Until the next time, keep looking for the good in the world, because sometimes it's where you least expect it.
We are not doctors and we don't play one on TV. If you need medical advice, consult with your physician or a healthcare professional. This has been a Shut Up production.
Shut up!